Hello, everyone. I'm Dr. Hitesh, advanced laparoscopic gastrointestinal, metabolic, and bariatric surgeon. Today, we're going to discuss about the one important topic, CA esophagus. So, carcinoma of esophagus is the sixth most common cancer which may lead to the death and the mortality. It is more common in the fifth and the sixth decades of the life, four times more common in the men than the women. So, most common type histopathologically is a squamous cell carcinoma. So in overall, if they are asking about the most common type of the cancer, it is a squamous cell carcinoma. But in Western country, it is the most common type is the adenocarcinoma. In India, most common site is the distal one third of the esophagus. But in overall, most common site is middle one third of esophagus. So if we talk about the risk factor associated with the carcinoma of esophagus, so two histopathological type. One is squamous cell carcinoma, one is the adenocarcinoma. Squamous cell carcinoma, the risk factors are smoking, alcohol, bulimia, achalasia cardia, human papilloma virus. In human papilloma virus, 6, 11, 31, 32 type is very most common. Other risk factors are like human papilloma virus. Again, there is a risk factor like saying bulimia nervosa. Then diverticulitis, most common is Jenkins diverticulitis. Other risk factors are like for the adenocarcinoma, it is a GERD called as a gastroesophageal reflux disease. Along with that, there is a problem with the scleroderma where there is a relaxation of the lower esophageal sphincter may lead to the prone for the gastroesophageal reflux disease and may leads to the carcinoma of esophagus. The other risk factors for the adenocarcinoma is the Barrett's esophagus. So Barrett's esophagus is a condition where there is a metaplasia of the squamous epithelium into the columnar epithelium. So it is a kind of the intestinal metaplasia. So now we talk about the how's the patient will going to present with the carcinoma of esophagus. So carcinoma of esophagus, usually the patient present with the dysphagia. So this dysphagia is progressive dysphagia. What meaning of the progressive dysphagia? When the growth will occurs into the lumen will going to become a narrow. So initially the patients have a dysphagia for the solid food. Gradually, once the lumen become a more narrow, it's more prone to the semi-solid and then ultimately the liquid. So that's why it's called as a progressive dysphagia. Along with that, the patients also have a weight loss, and sometimes because of the growth, the patient may leads to the aspirations and may lead to the aspirations, pneumonia, sometimes there may be the cough. So for clinical presentation, that depend upon the where the tumor is there. So sometimes suppose the tumor is going to involve into the recurrent laryngeal nerve, may lead to the hoarseness of the voice. So what investigation you will going to do once the patient present to you? So first investigations to look for the any abnormality. So first investigation is the barium swallow. When you do the barium swallow, it will going to give like a filling defect. This look like a apple core deformity. Now once we'll to diagnose, so investigation of choice to for the diagnosis is do the endoscopy and the biopsy. So that will give the definitive diagnosis about the carcinoma of esophagus. Now if you want to look for the early stage of the disease, so in the early stage of the disease, if you want to evaluate for the T1 or the nodal status, the good investigation is endoscopic ultrasonography. To look for the advanced disease, the investigation of choice is the CECT, thorax and the abdomen. So that will give you the idea about the tumor size, where the tumor is located and what is the conditions of the other organ. So that will give the idea about the any metastasis or not. But the good investigation to look for the metastasis is PET CT scan. Now once we diagnosed with the CA esophagus, now we have to plan for the treatment. So before that, we have to look for the TNM staging. So TNM staging include the T for the tumor, N for the nodal status, M for the metastasis. So for T stage, the as per the AJCC guidelines, the T stage include the TIS called as a high grade dysplasia, T1 the tumor confined to the lamina propria or muscularis mucosa, T1B where the tumor is confined to the submucosa, T3 where the tumor is going to involve the adventitia, because here in esophagus there is a no serosa layer. So only the tumor will going to involve the adventitia, and after that if it is a spread, so if it is involved into the other adjacent structure which is a resectable like a pleura, pericardium, diaphragm, that is come under the stage of T4A. T4B where the tumor involved to the other structures which is not resectable like trachea, vertebral body and the aorta. In N stage of the disease, N0 there is no nodal involvement, N1 involvement of the 1 to 3 regional lymph node, N2 there is involvement of the 3 to 6 regional lymph node, N3 there is involvement of the more than 7 regional lymph node. Now come to the metastasis. So for metastasis M0 there is no metastasis, M1 there is a distance metastasis. So most common site of the metastasis is liver, followed by the lung, followed by the bone. Now in esophagus, now we goes to the treatment part. So if the patients have diagnosed with the TIS, means high grade dysplasia, if the patient diagnosed with the high grade dysplasia, the treatment is endoscopic mucosal resection. Even if it is a stage T1, still their patient can undergo for the endoscopic mucosal resection. Now for the stage 2, which include involvement of the submucosal layer. If it is involvement of the submucosal layer, then depending upon the criteria, like if the size of the tumor is less than 2 cm, well differentiated tumor, or there is a there is no lymphovascular invasion. On those conditions, if all the criteria fulfill, the patients can undergo for the endoscopic submucosal dissections. Now, if it is a tumor evolving into the loco-regional disease, if it is a loco-regional disease, if it is a T1, patient can undergo for the directly for the surgery. And the surgery is we can do the minimal invasive esophagectomy with the limited regional lymph node dissection. If it is a tumor involvement of the nodal involvement like a N1, N2 involvement, then the patients can plan for the neoadjuvant chemoradiotherapy followed by assessment after the 6 week. If the tumor is a resectable, patient can undergo for the surgery. In case of the advanced disease, in advanced disease means T4A disease. In T4A disease, the involvement of the like a pleura, pericardium, diaphragm. In these conditions, the patients can plan for the chemoradiations depending upon the response and of the treatment, followed by plus minus surgery. So if they suppose like a metastatic disease, in metastatic disease called as a T4B. So in metastatic disease, only the plan of treatment is definitive chemoradiation. In conditions where like a squamous cell carcinoma of cervical part of the esophagus, in those patients we can give directly definitive chemoradiation therapy. There is no role of surgery in cervical part of the esophageal cancer. So sometimes the patients with the advanced disease can present with the tracheoesophageal fistula. In tracheoesophageal fistula, the treatment option is covered self-expanding metal stent. So if we summarize the things, then we can plan the patients for the surgery depending upon the stage of presentation. Now, if we talk about the surgery, what kind of the surgery. So there are the three main common type of the surgery. Number one called as transhiatal esophagectomy. So it's called as a Oringer transhiatal esophagectomy. In these operations, we're going to do the laparotomy followed by the incision in the neck. So here in the surgery, first we'll mobilize the stomach, will mobilize stomach, and the stomach will be survive based on the right gastric artery and the right gastroepiploic artery. After the dissection of the stomach, we'll will make a will do the dissections into the mediastinum, that is a blunt dissections. After that, mobilization of the esophagus will make an incision into the neck, and we excise the esophagus there, and then we'll deliver out that esophagus into the abdomen. Now, after making the tube of the stomach, we'll make a anastomosis into the neck of esophagus, and we make into the neck. So we'll make a anastomosis between the part of the stomach and the remaining part of the esophagus. So what's the problem with the Oringer transhiatal esophagectomy? So here in these operations, we do the anastomosis in the neck. So most common cause is anastomotic leak, but here the morbidity and the mortality is very less. But why it's happening? Because of the poor vascularity may lead to the anastomotic leak. Another surgery is named as Ivor-Lewis operations. So in Ivor-Lewis, we do the laparotomy followed by the thoracotomy. Here the thoracotomy is the right thoracotomy. So again the same, will mobilize the stomach, will resect the stomach, and will resect then we'll do the right thoracotomy. After the right thoracotomy, we'll remove that part of the esophagus and we'll do the mediastinal anastomosis into the mediastinum. Now, the major complication here is anastomotic leak. Though it is a very less likely, but if it is a leak, then it will be the major complication because the patient will end up into the mediastinitis. After the mediastinitis, patient may end up into the sepsis and those may lead to the death. So most common cause of the death in the surgery is anastomotic leak. Now the third operations is make-yawn esophagectomy. So in make-yawn esophagectomy, we do the thoracotomy first, mobilize the part of the esophagus, then we'll do the laparotomy. In laparotomy, we mobilize the stomach and ultimately the anastomosis into the neck. So here the step of laparotomy is almost similar with the transhiatal esophagectomy. Now here it is a massive surgery because we are going to do the laparotomy, we going to do the thoracotomy, and there is anastomosis in the neck. So here the major complication is the cardiopulmonary complication and may lead to the major comorbidity and mortality. So CA esophagus, the major problem is it is may lead to the sometimes the tumor may involve into the lumen, and then lumen may involve into the muscles layer. So from that muscle layer, it will going to spread to the adjacent structure. Then sometime may lead to the skip metastasis, and rich vascular supply may lead to the metastasis to the regional lymph node as well as metastasis to the liver. So here how to do the management. So in the management, if we talk about like resection, so in esophagus we usually do the total esophagectomy because here there may be chances of the skip metastasis. So margin is usually required the 10 centimeter proximal, 10 centimeter distal. Now what other option is there to reconstruct the esophagus? So the ideal most commonly used approach is stomach. So we make a tube of the stomach, and we'll do the anastomosis with the remnant part of the esophagus. The second option is colon. So in colon, we can use the left colon. Okay, that is based on the vascular supply of the left colic artery. And the third option, if it is not there, then the jejunum. So jejunum is based on the jejunal artery. So sometime the patients in the corrosive injury, in the acid burn or alkaline burn injury of the esophagus, on those scenario we commonly use colon as a conduit. So here we can use as a right colon, which or we can use for the left colon, but most commonly we prefer to the right colon. So the prognosis of the carcinoma of the esophagus. So prognosis depend upon the size of the tumor, depth of the tumor, and nodal status of the tumor. So most common route for the replacement of the esophagus in the corrosive injury or case of the carcinoma of esophagus is a posterior mediastinum. But in corrosive injury, we usually prefer the retrosternal route. So this is all about the brief summary about the carcinoma of esophagus. Thank you.